Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and allied health professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in basic sciences and applied clinical disciplines. In the virtual meeting held on 13 December 2022, more than 200 directors, deans, principals, CEOs, faculty members of the medical colleges and medical institutes decided unanimously that there is a need for the NAMS National Virtual Graduated Medical CME, Navigate Medico CME, program for PG students, MD, MS, DNB, MDS. Accordingly, the Navigate Medico CME program was launched on 22 January 2023 by the NAMS President, Professor Dr. S.K. Sare. Each online session is of 2 hours covering practical aspects as per the needs of the PG students in the identified theme areas. Thank you for your kind support.
So hello and good afternoon everyone to the next session of NAMS Navigate Medico online CME program. This time we are in continuation of our previous topic by Professor Dr. Rajendra Prasad sir. This topic is again very important, and this time we are discussing about National TB Elimination Program update. So just to initiate the session, I would like to request Professor Umesh Kapil sir, Secretary, National Academy of Medical Sciences, for the welcome address. Over to you, sir, please.
Namaskar and thank you very much, Digambar. We are most grateful to our resource person, Dr. Rajendra Prasad sir, who is a doyen in the field of tuberculosis. His contribution is not nationally but internationally known for his original work. Dr. Rajendra Prasad has done almost a lifetime work in the field of tuberculosis. As you all know, that tuberculosis is one of the most important public health problems in our country. And we do have still a large pool of tuberculosis, and it is changing its profile. Initially, it was controllable, but with multi-drug resistant tuberculosis, we are finding it difficult to tackle them, particularly those MDTR cases who have been developed because of incomplete treatment. Plus, they are residing in the remote areas, hence the diagnosis and the management becomes slightly difficult. NAM started this Navigate program about 2 years back with the aim that the continuing medical education should be provided to all the postgraduates and young faculty members in different specialties of medical colleges, AIMS, Institute of National Importance, so that they are aware about the latest and most recent developments in the field of tuberculosis or the common ailments. Now, the aim is to ensure that we reach the last mile or last doctor in the network of tuberculosis program, because tuberculosis is not limited to urban area, also in the rural area, tribal area, and we do have difficult situation. We do have a changing profile of national tuberculosis. Initially, it was control. Now it is elimination program. And Prime Minister of India, Shri Modi ji, has given a maximum thrust to this particular program so that we are able to make a joint effort to ensure that we are able to eliminate the tuberculosis from the country. The recent data do indicate, yes, there is a declining trend in the prevalence of tuberculosis. Now, what we do is that we keep all these lectures and presentations on our NAMS virtual library so that any doctor who is not able to join us today or who is joining on the YouTube, they may access our NAMS library and for all time to come. So we have almost a compilation of 70 lectures who have been delivered by the most eminent scientists in the country. And we look forward to Dr. Rajendra Prasad's lecture and presentation, which will give us more insight of the recent advances in National Tuberculosis Elimination Program. Thank you very much, sir. And over to you, Jaswant.
Thank you very much, sir. Next, we would like to listen a message from Dr. Digambar Behera. Sir is the president of National Academy of Medical Sciences, and this message is to guide all the new doctors of the country who are attending this program. So I request Mr. Raviji to please play a message.
My dear young colleagues, faculty, and officials of the National Academy of Medical Sciences, a very good afternoon to all of you. With immense pleasure, I invite you all to this program. National Academy of Medical Sciences, that is NAMS India, it was established on the 21st April of 1961 with the objectives of promoting the growth of medical sciences. It was inaugurated at New Delhi on 19th December 1961 by Pandit Jawaharlal Nehru, the first Prime Minister of India. The NAMS fosters and utilizes the academic excellence of health professionals in the country as its resource to promote excellence in medical education and skill development in the field of medicine and allied sciences. The Government of India has recognized the Academy as a nodal agency for promoting continuing medical education for medical and allied health professionals and is advising the Government of India on several matters of national health policy and planning. The best in the field of medicine are part of this umbrella organization, and who is who of medical science guide the NAMS. The National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia, and workshops in basic sciences and applied clinical disciplines. The aim of the National Virtual Postgraduate Medical CME is to facilitate the postgraduate students and young faculty members to increase their knowledge in the medical subjects, to navigate them to be more proficient in their profession and pass their NEET and PG examination to become better doctors, eminent biomedical scientists, teachers, and researchers. As a part of this responsibility, NAMS, in collaboration with the AIIMS New Delhi and 16 other AIIMS-like institutions of the country, has initiated this navigation program in the form of dialectical lectures and discussions. The program is regularly held every first Friday of the month at 3 p.m. The best and useful topics are carefully chosen, and the best teachers from various AIIMS are picked up to prepare and give these lectures. I am sure you all will enjoy these talks and will like them and found them useful in your future lives. Thank you.
Thank you for the message. So now it's my turn and honor privilege to invite and introduce today's speaker, Professor Rajendra Prasad sir. Sir, it's my I would say second opportunity to introduce you in the same CME. So, sir is currently Director, Medical Education and Professor of Respiratory Medicine in ERA's Lucknow Medical College and Hospital in ERA University at Lucknow. Sir is Vice Chair of National Task Force regarding anti-EP and RNTCP India. Sir is also Emeritus Professor of National Academy of Medical Sciences. Sir is also Emeritus Professor of Indian Medical Association. Sir is Chairperson and Convener of State Chapter UP for National Academy of Medical Sciences. Sir has held various positions, including Director of Vallabhbhai Patel Chest Institute at University of Delhi, Director of UP Rural Institute of Medical Sciences and Research, CEFI, had pulmonary medicine at KGMU Lucknow. Sir has special award and recognitions, including International Governor of American College of Chest Physicians USA, and Sir has been president of 5 major associations in chest medicine. Sir has been awarded with prestigious Dr. B.C. Roy National Award for developing pulmonary medicine in India. Sir has also received Lifetime Achievement Award of Indian College of Allergy, Asthma and Applied Immunology. Also, Dr. R.V. Razam Academic Oration Award of National Academy of Medical Sciences, Robert Koch Oration Award, Lifetime Achievement Award by Indian Chest Society, Dr. R.C. Jain Lifetime Achievement Award by Tuberculosis Association of India, NCCP Professor M.M. Singh Memorial Lifetime Achievement Award, Lifetime Achievement Award by Thoracic Endoscopy Society of India, also by Indian Association of Bronchology. Sir has been awarded with TAI Oration Award of Tuberculosis Association of India, Vigyan Gora Award of Council of Science and Technology, Government of UP, Dr. Reddy's Lung Cancer Oration Award of Indian Society of Study of Lung Cancer, OA Sharma Oration Award, Indian Chest Society, M. Shantosam Oration Award, Indian Association of Bronchology, Indian Chest Society Honor Lecture Award, second ICAAI Foundation Day Lecture Award, Indian Medical Association Dr. Venkata Rao Oration Award, O.A. Sharma Guest Lecture Award, Professor Raman Vishwanath Memorial Chest Oration Award, Dr. D.N. Shivpuri Oration Award of Indian College of Allergy, Asthma and Applied Immunology, and UP Ratna Award. Sir has published numerous original articles, reviews, and book chapters, including more than 600 articles, and supervised 215 researches and theses. Sir has also authored 12 books, including 4 books on tuberculosis, including Atlas on Fiber Optic Bronchoscopy and Manual of Chest X-ray. Manual of Chest X-ray in 2 volumes based on Indian patients. Also, Sir has been ranked among 2% scientists in previous year ranking by Stanford University. So, Sir's citations are around 10,000 and H index of 48, that is very significant, and I-10 index of over 232. So with this brief introduction, I would like to uh, welcome Sir and invite Sir for the wisdom of pearls for all the newly emerging and budding doctors like us. So over to you, Sir.
Thank you, Jaswant. I must say, for a very elaborate introduction. And I must thank the National Academy of Medical Sciences for inviting me for this important lecture on National TB Elimination Program, an update. And now I would share my slides. And my slides are visible, I believe.
Yes, sir. They are perfectly visible and you are very much audible, sir. Thank you.
Thank you, sir. Thank you. You know, whenever I start lecture, I remember this great man, and he said that if you want to shine like a sun, first you have to burn like a sun. At least this is most of the time is attended by the PG students and younger faculty. So it's the most appropriate. Many people ask us, sir, how you have to reach to this place and how you have achieved all this. It is only because of the sheer hard work and nothing else. And then I would, since I was in Japan at my early career of life, 1989, I learned this, that better than 1,000 days of diligent study is one day with great teacher. I'm not saying that I'm a great teacher, but I said these words to my own mentor, late Professor B.K. Khanna. Because what I say that whatever I am, whatever I know, the tuberculosis, chest disease, oblique pulmonary medicine, it was Professor B.K. Khanna who mentored me. So I always remember in my lectures, wherever he will be there, he should be feeling very happy. Then as I start any lecture, 2, 3, although this has been told by the video, but I would like to tell since the PGs are attending maximum. So I'll say it about 2 slides about the National Academy. This has already been said that it has been established in 1961. And then how you can be associated with National Academy, that is my interest. In one slide I would like to show. Yes, senior person can become fellow. You can become member. If you have postgraduate degree and 5 years of experience, have minimum of 3 publications, you can go for this. If you are DM, MCH, RM, and you can apply for associate fellowship. If you are less than 45 years, this is a new thing has started. After DNB, MNMS is automatic, but you have to fill the form. And there's a new associate member. Anybody who did MD, MS, or MDS in first attempt, and he can apply, had presented one paper, he can apply for associate members. You can be associated. Of course, you can become, senior people can become emeritus professor. So as far as associate member, I would like, it's a very easy, for membership, you can, or fellowship or emerit, you can download on the web, from the website, the application form, and you can go ahead. For associate membership, which was introduced, I think, last year, it's a very easy, anybody I said who did MD, MS, MDS, even PhDs, MSCs, they can become member very easily. And application, you need not to be forwarded even by fellow, head of department, head of the institution, head of the unit. Any fellow can also nominate, and applications are accepted throughout the year. And this is the link from where you can download. So what I'm trying to say, if some of you postgraduate, immediately you can think of applying for associate member. If you, after your post-graduation, you have spent about 5 years in career, you can think of applying membership. And senior people can think of fellowship and emeritus professorship. So that is how one can be associated. Now I think in next 40 to 40, maximum 40 minutes, 40 to 45, I'll be summarizing something about National Tuberculosis Elimination Program. It's an update. Now, whenever I speak about tuberculosis, I used to say that it's almost curable disease, provided somebody prescribes well and patients take those medicines. These are the 2 provisions. Then it is almost curable disease. But it is unfortunately that about more than 3 lakh people died last year, as per WHO Global TB report last year. And we have, India has highest number of TB cases, about 28 million, about 30% of the global burden. And I always think, why happening. In my first slide, I said it's almost curable disease. But this is happening because every patient is not getting the proper treatment. That is the reason. So with this, let me go to the little bit history of national TB control in India. You know, in 1962, the first time in 62, government of India has launched national TB program and set up a district TB center. Then in 97, this program was revised and was known as Revised National TB Control Program. It was also known as DARTS program. Then then subsequently in about 2005 and 11, second phase of RNTCP started. And finally, this name was changed in big end of 19 as National TB Elimination Program. Why we are saying National TB? Because we are moving towards the goal of TB elimination from the country. And this is the structure of the NTEP. We have at center, what Center TB Division we call it. It is the Ministry of Health and Family Welfare. Every state has state TB officers. Then every district had district TB officer. There are more than 7,000 TB units and more than 1.6 lakhs Ayushman Arogya Mandirs. There are a lot of diagnostic laboratories, lot of private health facilities, labs have been utilized in this program. That is what is the structure of NTEP currently. And you know, when we started in 1962 as a TB control program, some of you might be remembering these were the conventional regimen, including injectables, say streptomycin, INH, ethambutol, thiazidone. Those were the even past. Those were the drugs were used. There are 4 types of regimen. So it was started in 1962 for the first time. And then when it was evaluated after its 30 years of existence in 1992. And what was the result of that? It was evaluated by Government of India along with WHO and Swedish Development International Agencies. And they found in one line, if I have to prescribe, I have to say that the program has not made any dent. So initial TB control program was made in 62. In 30 years, up to 92, they have not made any dent. Big reasons were very obvious. Inadequate budget, overemphasis on X-ray, poor quality microscopy, emphasis on detection rather than achievement of cure, poor organizational setup. So the completion rate was in those days. I have seen those days as a PG student, at lecturer, and then lack of consensus among practitioners regarding TB rate. So those were pointed out by that evaluation team. So what government did, so they declared emergency in 1993 on tuberculosis, and then RNTCP, then the RNTCP came. Whatever problems we have observed in NTP, means National TB Control Program, in RNTCP, those things were taken care of. And RNTCP is a very famous, you know, it was consist of political commitment, diagnosis by good microscopy, adequate supply of the right drugs. That was the basic issue, what you call it. And then we have directly observed treatment, what was DOTS. And finally, accountability. Every record is being kept from RNTCP days. So these were the essential components of RNTCP. And RNTCP was based on the Millennium Development Goal, what we call it as MDG. And the aim indicator 23 of MDG was between 1990 to 2015, you have to do half the prevalence and the mortality. So you have to reduce the prevalence and mortality by 50%. That was the aim. And the indicator were at that time detect 70% of the infectious cases and successfully treat about 85% of them. That was the idea of Millennium Development Goal. And we are happy to share with you that whatever goal was there for the RNTCP, up to 2015, we have been able to fulfill those. Incidents have been, before that, it was nearly about, it has been half, and then even mortality has been reduced. So that was the idea of millennium and targets were achieved. And when government saw that now we are started showing some good points, targets, near targets. So now government has changed the name of this program, and now our target is actually eliminate tuberculosis. That's why this program is known as TB elimination program, NTEP. And what is NTEP? That you have to understand. Many of the politicians sometimes ask me, being a very senior in the state of Uttar Pradesh, sir, really the TB will end from UP and India? So I used to then, this is a very distant dream. Yes, we have a dream of it, TB-free India, but we are working currently on and this goal was end TB strategy. When we say end TB strategy, what do you mean by end TB strategy? End TB strategy, the targets were, this is the sustainable, that was MDG in RNTCP and NTEP, this is a sustainable development goal. And by 2030, what is the aim to end TB? This is the end TB, on which goal we are working at currently. There, the reduction of TB deaths compared to 2015 level, it should reduce by 90%. And reduction in the TB incidence, it should reduce by 80%. And there should be no catastrophic expenditure due to TB. That was the aim of an end TB strategy, which was formulated by WHO in 2014. So from 2000, so everything is talking at the level of 2015. Well, the government of India, there was a summit in 2018, what was known as Delhi End TB Summit, and where the Prime Minister Modi himself was the chairing that session, along with Health Minister and WHO persons, all the WHO persons, and there we declared, India declared that we will achieve end TB strategy not in 2030, 5 years earlier, that is 20. So that was the basis why we are talking NTB strategy by 2025. So we were, even Dr. Bera, I and Dr. Arora attended that particular meeting in 2018. And this slide will tell you very clearly, this was the aim of, as I said, in 2015, the incidence in India was 237 per lakh. And if you have to reduce by 90%, by 80%, so it will come as 47. So target is by the end of 2025, it should be 47%. Same way, mortality, it was 28 per lakh in 2015, and then it should reduce by 90%. So it has to come down nearly about 3 to 4 per lakh mortality. So that is the real end TB strategy targets for India. I'm talking for India. With this target, we have made a national strategic plan in 2017 to 2025 for 8 years. We are still working on this strategy. And there we have made 4 components that detect every fine dull TB cases wherever they are, including the private sector. Then second component was treat all the cases with high quality anti-TB drug. And the third was the prevent. Preventive treatment was not there, but that was the third component. If you want to achieve this national strategy, prevention was prevent the emergence of TB in susceptible population and stop catastrophic expenditure due to TB by all. And the fourth component was build and strengthen supportive system, including enabled policies, empowered institutions, and human resources. So that was the idea of National Strategic Plan 2017 to 2025. Very lately, since 2000, we have reached in 2025. So I attended this meeting even, the National Consultation Workshop on Development of National Strategic Plan. Actually, it will go ahead 25 to 30 for TB elimination. It was held in February 25. And then there are many thematic areas which were discussed, because how you reduce further incidence, mortality reduction, out-of-pocket expenditure, strengthening health systems, strengthening multi-sector involvement, strengthening surveillance, supervision and monitoring, and research. These are the components which it will very soon. It was discussed in depth, and I personally attended this meeting, and so I'll skip. There are many strategies to reduce TB incidence, to reduce mortality, and so to have this, what we have, that we have a lot of labs. We have in country 6 national reference, what we call NRL. We have got 37 intermediate reference laboratory. They are very high quality labs for TB diagnosis. And then we have culture and DST laboratories around 63, 64. And then we have district or sub-district level. We have molecular diagnostic, culture, NAT. We have peripheral level microscopy, and about more than 25,000. So quite extensive network of diagnostic facilities are there. With all these, and this is available free of cost. And so with all these newer tests, the diagnostic algorithm of drug-sensitive TB was revised, in which the smear, chest X-ray, and mainly emphasis on CB-NAT, newer molecular diagnostic test. And then after that, we have also even revised the integrated diagnostic algorithm for drug-resistant TB. You have got many types of drug-resistant TB, so there probably main test is a NAT, means CB-NAT, a true NAT. There we advise that whether it is a rifampicin resistance, whether rifampicin resistance not detected. Depending on that, we further do first line LP, second line LP, liquid cultures, DSTs, everything we do, and we decide that whether patient is a drug sensitive, patient is a mono-resistance, patient is a MDR TB, patient is a pre-XDR TB, and patient is XDR. So all the diagnostic work algorithm has been beautifully worked out, and it is working throughout the country, and NTP is working on the same basic principle. And now, initially, when case finding was there, it was a passive case finding. I hope some of you might remember, there was a Bangalore survey who said that people who have TB, they will come automatically to them. Now we are moving from passive, we are moving to the active case finding. In this, there is intensive TB case finding, especially the vulnerable patients like undernourished, alcohol use, smokers, diabetes, HIV. There we do active search. That is known as intensified TB case finding. And there were a lot of measures were taken to improve the case finding, like bidirectional TB. For COVID screening, you have seen in COVID period, active case finding in the community. People are going into community because many times the TB you find they are asymptomatic. So the only passive case finding will not. So government has started doing active case finding. And there are many other issues, strengthening of H1 implementation, chemist even notifying whosoever is purchasing the anti-TB, mandatory notification by the private providers, the patient-provided support agency like JEET and domestic resources, and there are guiding documents how the partnership can. So RNTC and NTP has worked beautifully on these guidelines, and guidelines are available. And there's another issue that initially we have 4 symptoms. Screening for tuberculosis for presumptive TB, but now we have got 10 symptoms presumptive TB, that is cough, fever, night sweat, weight loss, hemoptysis, shortness of breath, chest pain, loss of appetite, tiredness, nodular neck swelling. So all are any extra. So all those has been TB, presumptive TB, and there are even, as I said, there are even asymptomatic TB screening. Vulnerable population is done, especially in household contacts, HIV, and many diabetes, alcoholics, smokers, coal workers. This is what I'm trying to say. Recently in NTP, there's an active way we are moving towards the active case finding. And with these results, now you see that when we see the 2015 gap between the incidence and the notification was very large. About we always have said a missing million, but now this gap by 2024 has been reduced to hardly about 2 lakhs. Still some cases are missed, but it has been drastically reduced. Even the private sector contribution has increased a lot. So there is involvement of private sector. That was one of the concern area when NTP was there. So that was also addressed to the extent. And then even MDR TV, in 2017, hardly about 38,000 MDR. Now last year we have detected about 64,000 MDR TB patients. So TB treatment, and that was all the diagnostic element. Then as far as treatment portion in NTP, although I took a lecture on treatment last time, but one of the standard, they say for each patient with pulmonary TB, a set of public health actions should be conducted. And what are those public health actions? Notification is now compulsory. Contact investigation, as we have introduced the preventive treatment, so contact investigations are also being necessary. And then after completion of the treatment, now we have a long-term follow-up. So when patient complete the treatment in the National TB Elimination Program, we are doing a long-term follow-up up to 2 years, every 6, 12, and 18 and 24 months. So, and treatment is available for drug sensitive and drug resistant. And this is the diagram which talks about every shot of a treatment, say for drug sensitive treatment, 4 drug followed by 3 drug. For INH resistance treatment, where INH was replaced with levofloxacin for 6 to 9 months. Then we have MDR, pre-XDR, and XDR TB treatment. Now, new regimen BPAL has been introduced. The first choice should be BPAL. If you can't use BPAL-M, it is for 6 months. Believe MDR was treated for 2-3 years, and now it is for 6 months. And then if it is not possible to do that, use for shorter MDR regimen for 9 months to 11 months. And still, if you cannot use this, then we have. So these are the three regimens for the drug-resistant TB. So that was the idea of this is the, and there were a lot of revisions in the treatment, like revised definition of universal drug susceptibility. Every patient we are treating, you must know the drug sensitivity. Pan-country rollout of shorter oral MDR regimen, Videculin MDR patients have been introduced, even at least who are less than 50, even 15 kg. Delaminid being used in the country, who is weighing at least 10 kg. Use of Videculin has been introduced during pregnancy. Introduction of the preventive treatment of the MDR TB has been introduced. And shorter TB preventive treatment of 1 month, having say rifampicin and isoniazid has been introduced, and 12 dose, if you are using weekly, it is a 12 dose that is. So these, and BPAL-M has been introduced. So these newer initiative has been taken in the treatment, and with the treatment, the outcome has improved, drug sensitive around 85%, and even drug-resistant TB, when we used to see about 5 years back, not with new regimens, the outcome was around less than 50%. Now these outcomes are reaching to about 65 to 70%. So even there were a lot of collaboration between HIV and TB and diabetes. And Nikshar Posar Yojana for nutrition has been revised recently. Initially it was 5,000 per month, now it is 500 per month, now it is made 1,000 per month. And even incentive for treatment supporter, incentive for notification and outcome, and travel support. Every support is being given in NTEP. We have a Niksha Sampark call center where when one can call if there is any problem for tuberculosis. I was talking about TB preventive treatment. So TB preventive treatment, a lot of patients have been put on the preventive, because now we know if we want to achieve end TB strategy or eliminate TB without preventive TB. So country, it has been introduced in 17, and large number of people have been put on the preventive treatment. And then we have a new initiative like BCG adult vaccination has been started. It is still going on. I'll skip. It's a nitty and gritty in the interest of the time. And this will be study will come and we'll see that whether adult BCG vaccination, revaccination has any role in TB elimination or not. We have another program, but you must have heard, TB elimination program, 100 days campaign. Government has started, and they have started this 100 days campaign was to increase the case detection and to decrease the mortality. With this hope, they have set goals to define that who will go for this, where death rate is more than 3.6 and presumptive TB examination is less than 17. Even death rate is more than 3.6 and examination rate is more than 17. There are areas they have defined, and this has been worked. I will share in the end, the Prime Minister took a very meeting on 14th of May. I'll share that slide. So they are identifying this large number of cases and complement, and it was for 100 days. I hope it will be extended in the country, and with expected outcome, detect additional 2 lakhs cases, at least 90% screening by X-ray, listed vulnerable individuals. So 100% coverage on Niksha Posar Yojana, and 50,000 panchayat prepared for TB-free notification. So those were the ideas is going on. Medical college, this is a one program where medical college involvement has been there. And why it has been there? Because all the teaching were done in the medical college. Future program runners, they will be trained in these medical colleges. So their mindset has to change. And structure being National Task Force. We have National Task Force. I currently being a vice chair of National Task Force. Then we have 6 zones in the country, zonal task force. Then we have each state has a state task force. And then we have core committee. Every medical college has a core committee. That is how this task force work, and the purpose of this task force in engagement with NTP, training and teaching, main idea, advocacy of the program, and operational research. These are the 4 components of task force. I'll not go in any details. And the function of the core committees are there. Every 3 months, core committee meets in every medical college throughout the country. And then there are a lot of programs, a lot of collaboration is happening between NACO and tobacco control program, population-based screening of TB, and then diagnostic treatment support. So everything is happening in Ayushman Bharat, and a lot of other agencies have been involved, like Ayush, like railways, defense, and tribal mode. And now there are states which are showing interest that TB elimination or NTB strategy will be met in certain states very soon. And even Honorable President of India launched Pradhan Mantri TB Mukt Bharat Yojana in 2022, and additional diagnostic and nutritional vocational support to TB treatment, encouraging community to have a Nikshay Mitra donors and bring together people in work. So what I'm trying to say with these updates, the NTB, even Modi ji again addressed in Varanasi on 24th March 23 that India, one world, one TB summit, and that was India first for a new model for global war of TB is there. And then on 13th March 2018, what was declared NTB strategy, up to what portion we have reached, how we can see this slide. You know, we have reached. I'm happy to inform that if I can, I'm happy to inform that it was our aim. Mortality reduction should be 3 per lakh. I have shown you already. Reduction in TB incidence about 45 per lakh. And there should be 0 catastrophe. That was what was the thought. And what we have achieved by the end of 2020, still we have 2 years. And that we have achieved is instead of 3 per lakh, our death rate is still 21. We have reduced. We actually TB reduction has happened with the rate of 21%. And then decline in TB incidence was about 17%. This was and affected TB affected families facing catastrophic cost was around 90. It was little away from whatever our aim, but still we have got 2 years to go. Because this is the data up to 2023. We'll analyze this year 25 for 24 data, and in the 26 we will analyze the 25 data. Then probably we'll see that from. But this is a good thing that the world is we are far ahead than the world scenario, and this is what I was trying to say. The PM took a meeting, chaired a meeting on India's mission to eliminate TB on the 13th of May this month. And they say, and he said that PM reviews the status progress of TB Mukt Bharat Abhiyan. And I'll not read everything. And he was very happy to say that early detection and treatment of TB, lauding the significant progress made in early detection and treatment of TB patients. Reviewed the recently concluded 100 days program, which I have already alluded to, that a lot of TB, about 7.1 lakh TB cases were detected in this program. and instead the need for to analyze the trend of TB patient, urban, rural, and so many issues he raised. And he also highlighted, he said that TB is now curable with a regular treatment. There should be less fear among and more awareness in the public. So these were, and this is what he shared, that finding of WHO TB Global Report 24, which affirmed an 18% reduction of TB incidence from 237 to 195 per lakh, which is double the global reduction. Then it was 21% decline in TB mortality, from 28 to 22, and even an 85% treatment coverage. So what I'm saying, he showed some satisfaction. Still, we have do a lot of work. Still, there are a lot of challenges. I see, although I'm not a program man, but I have been in the task force. We are the rather we have started this task force, medical college task force. I was the founder member, and I have been STF chair, ZTF chair, and now NTF vice chair. But still we see challenges. Reaching the unreached, huge reservoir of latent TB infection is still untreated. Social determinants outside the health we have to tackle. Quality of care in the private sector is still some questions are. Stigma is still, TB has a big stigma. Although TB Association has a program against the stigma and poor outcome, still probably drug. Although we have come a long way, newer drugs have been introduced. But these are the challenges, and what I say in the end, that really it is time to come together to end TB. And I used to say, probably everyone at work has to work in a mission mode to end TB from this country. And when we'll end TB from this country, it will be then we can have a dream for TB elimination, which I said is a distant dream. So that was the well, in the end, I say that even these lectures on the YouTube and these lectures will be asked. So since PG has joined, so I have a very interest. I have a lot of YouTube lectures, how to take history, how to do physical, how to do auscultation, how to read chest X-ray. Books I have already told, many books, and last book I have on a chest X-ray. So I would like to end my lecture and by saying this word which I like. Two more slides I have. As a PG, there are younger faculties attending, and I always say a doctor is a student till his death. When he fails to be student, so you have to keep on learning. Without that, you cannot practice. This was said. William Osler was very famous clinician, and he said these words. So and then last slide, I say anyone who keeps learning, that is another motivator for learning. If you want to remain young, anyone who keeps learning stays young. This was, so that's why, thank you very much. And I still, once again, I thank you, the National Academy of Medical Sciences, for giving me this opportunity to share some of the NTEP updates, which has been recently being done. And if you have any question, I'd love to answer those questions. Thank you very much.
Thank you very much, sir, for such an interesting presentation. And that was, I would say, one of the most recent updates were included, since you are already there in that position in policy making. So thank you, sir, for enlightening us with the latest advances. So there is one question, sir, which is more of clinical rather than policy based. So this is from Dr. Jay. So for peritoneal fluid TB detection, the ADA levels are as same as pleural fluid, like more than 40, or it is less?
I think ADA levels are for pleural and peritoneal, it is the same. For the TBM, it is less. TBM is around 9 to 10.
Sir, one question from that I wanted to ask.
Yes.
Since RNTCP and then the current NTEP, so during this process, during the change of nomenclature and everything, has the organizational structure also been changed or it's same? Like,
Yes, organizational structure has drastically changed.
okay, sir.
Initially at district levels, taluk level, now it has come to the primary care centers level. So, of course,
Right.
that has also changed accordingly.
Right. So this will bring definitely a lot of change since we are reaching the root levels.
Yeah.
So yes, sir. Thank you, sir. So I would request all the participants, since we have around 70 participants over Zoom itself and more than 100 participants over YouTube. So I request all of them. You can put your queries in the chat box or in the Zoom. The people can just raise their hand and we can unmute them for uh, that particular time when they want to ask their queries. If anyone want to ask, they can raise their hand in the Zoom, and then we can just unmute them.
I usually say, Jaswant,
Sir,
when people don't ask the question, there are two interpretation I do usually.
sir.
Either the audience has understood everything or he has not understood anything. I don't know what is. So
Sir,
I
the
always encourage my PGs to please ask questions.
sir, but
It is not
here
that we
what
will
I
able to
understand,
answer every question, but
sir,
if we will try to do it with my all might. We will try
sir.
to answer those questions.
But sir, the slides were so clear and like so elaborative. I don't think that if there would be much confusion after seeing those slides and listening to you, because everything was explained in a very simple manner. So the possibility of first scenario is higher that
Thank
they
you,
have
Jaswant.
understood everything, sir.
Thank you, Jaswant.
Sir.
Actually,
So,
I'm taking this lecture from KGMC itself. I here came
sir,
for some meeting, and then I
okay, sir.
arranged here. And
Last time
last
you were at
lecture I took from the Pondicherry.
Pondicherry. Yes, sir. I do
Yes,
remember
yes,
that,
yes, yes.
sir. Right, right, sir. Okay, so sir, we are not getting more questions. So I think we can request. We can call for the sir. I think Sood sir. There are no
Thank
more
you.
questions, so I would request Professor Ajay Kumar Sood sir for the word of thanks. So, sir is the Deputy Secretary of National Academy of Medical Sciences. Sir, over to you, sir.
Thank you,
Well,
Dr. Jaswant.
is there any time frame or day fixed for NTEP? Like,
Yeah, thank you, sir. Sangram sir, can you please repeat the question?
yeah, is there any deadline or a date fixed for National Tuberculosis Eradication Program by this days, this end, this month, like any slow these things?
Well, it
Cutoff
was,
date.
it was naturally, the 25 results will come in 26. Because whenever these results come, because whatever I shown, it is up to 23, but 25 is a cutoff date. Still, it has not been increased. Although we are going little slow, and slow reason was very obvious. Actually, we have lost about 3 years in the COVID.
Yeah,
We were
because
we were expecting that probably these timelines might increase, but still the government has not increased. Still, they are insisting on by 25, but 25 result will get in 26.
but still it
Because
is difficult, sir. Difficult new cases, active cases, lot many cases are there.
yes, I know it's a very challenging and very difficult. But one thing has happened, I must say. I'm from medical college. I'm basically teacher. And I said that I'm not from the program side. I'm from the teaching side, from the medical. But we have a lot of interest in the program from very beginning. So one thing has happened. Suppose PM has not fixed a target of 25. So whatever we have achieved, probably this could have not been achieved. Now we have introduced all new diagnostics, all new treatment. Can you believe that BPAL-M is the 6 months treatment for MDR TB. And everything has been there in this country free of cost. Of course, how much people are utilizing will depend on that. Still, all the people are not utilizing that. But at least from the government side, they have made everything available. Newer diagnostics, even the newer vaccines, a lot of research is being done because we know probably BCG vaccine is not very helpful. So, we are searching for, and then preventive treatment, which was not there about 5 years back. Preventive treatment was also introduced in the country. Now, can you believe that we have got 1 month of, initially when I was a student in 70s, 80s, we have preventive treatment for 6 months to 1 year. Now we have got 1 month of preventive. 1 month daily means rifampicin and isoniazid daily for 1 month. And if you are using it once a week, so 12 dose preventive. Because nobody would like to take preventive who has no symptom. Nobody take like these drugs for 6 months to 1 year. So there's a lot of innovations has happened in the world, and what India is catching those innovations very fast. That is a good point. And what I appreciate is at least when you fix a target, if you are not even able to achieve that target, but at least you will be reaching somewhere near the target. That will finally work. Will work finally on elimination of TB from this country. That is TB-free India.
Yeah, thank you, sir. Thank you.
That's my dream also. I hope in my lifetime probably I'll be able to see these dreams to be true.
Thank you,
How
sir.
about this HIV and tuberculosis, diabetes and tuberculosis? Anything, any particular
Yes,
thing?
function. The program has bilateral screening of TB, HIV, bidirectional, and then diabetes and TB. The intensified TB program and these are the special groups where screening of tuberculosis is being done. There's a lot of progress into it.
That was a really interesting question, sir.
Okay, thank you so much, Dr. Jaswant. On behalf of the Academy of Medical Sciences, it is indeed my great privilege to thank our senior council member, Professor Emeritus, and Dr. Rajendra Prasad, sir. He has kindly agreed to cover very important issues in tuberculosis in 4 sessions, despite his very busy schedule. And today, again, he's not in UP. So thank you so much, sir, for your concern with our PG student. And we look forward for your blessing in future also. I am very sure that, as Dr. Jaswant said, all these sessions are going to be very, very useful for our PG student as well as a clinician. And our secretary said all these will be put on our website so that the student can take benefit from that. So again, once again, I make an appeal to all the participants, especially the PG student, don't miss this session. Sir has more than 6 decades of experience of working on tuberculosis. I don't think anybody else has such a vast experience. So next session in June will be again on COPD, and the next session, which is in the month of July, will be on radiology, chest and tuberculosis. So please remember that third Friday is for tuberculosis. So thank you, sir, for your presence today. I will also like to thank all the distinguished participants, especially senior faculty members. We have some of our NAM state conveners who have also attended this, and all the deans, directors, and faculty members of various institutions who have supported this program. This is your own program, and we look forward for your support and blessing. Please give your suggestion how we can make it better. And some of the faculty members who are interested to take session, please write to us. We'll be happy to include your session in some of the future session. So thank you so much. So I will like to inform all the PG students. Please remember that first Friday we have ophthalmology series, which is coming up from the month of June. The session on 6th of June is on strabismus, which again is going to be taken by a very senior former faculty member from RP Center, AIMS, New Delhi. Nowadays, he's with the Center for Sight. And like that, we have 5 very interesting topics on ophthalmology, which are important clinically as well as from the examination point of view. The other session will be on diabetic retinopathy, then on glaucoma, surgical management of glaucoma, management of pediatric stoma, eye, and then on eye bank and eye donation. So don't miss this session on first Friday from 3 p.m. So I will also mention that NAMS, in collaboration with IIT Hyderabad, has started a 12 weeks online course on artificial intelligence for health professional. The last year we had very good response. Nearly 192 PG student and young faculty member has started. And we have shared the detail of this brochure in the chat box. And the next course is starting in the month of June. So those of you who have not still applied, so you can go through the brochure. And if you feel interesting, you can definitely apply for that. So this again is very useful online course. In addition, we have an ICMR NAMS National Biostatistical Helpline. This is again for young faculty member as well as the PG student who require biostatistician help. There we have senior members from fellows from National Academy as well as experts from the ICMR who are going to sort of help you in the statistical problem dealing with your thesis or research work. These details again we have sent you on the chat box, and also they are available on the website of ICMR as well as the NAMS website. Another information for faculty members, especially the senior faculty members, that NAMS Council has approved from 2025 academic recognition of excellence, and there are 24 areas, theme areas, where the NAMS is going to recognize the eminent medical, biomedical scientists from the country. That information again we have put on the chat box, and this application form is available online, so you can apply online, and the last date is 31st of July. So please make use of these new information which you can share with your colleagues as well as with the faculty member. So once again, I would like to thank here Mr. Dr. Jaswant sir for being with us for so nearly 3 years. He has been helping us despite his very busy schedule in moderating the session so well. Thank you, Dr. Jaswant, for your support to the Academy. Here in our Academy, we have an IT team led by Mr. Ravi, who has been writing you letters, reminding you, sending you, then also ensuring that this is transmitted on the YouTube and also put on the NAMS website. So thank you, Mr. Ravi and Mr. Shivam, for coordinating. Once again, thank you all for making this session very, very interesting. And again, we look forward for your blessing in the next session, which we are going to have on 6th of June, which is on ophthalmology. Thank you so much. Over to you, Dr. Jaswant.
Thank you, sir. And it's also my pleasure to be with NAMS and to work with all of you. So again, sir, we have an opportunity to listen to eminent professors, eminent speakers like Professor Rajendra Prasad, sir. And so I'm also grateful to the NAMS, sir. Thank you, sir.
Thank you.
So I think with this, we can mark the closure of the session. Thank you, sir.